Hello there, I'm Tony Meekum. So this is the last lecture of this course, and it's kind of a review. Hopefully you can kind of have fun with this one. The idea is these are lesions that are very specific. They have a very specific radiographic appearance on our imaging. And so hopefully, like these people in the background, you can immediately recognize them. And that should be the case for these lesions as well. So nothing new in this lecture, but just rehashing when there's a very specific appearance that leads you to a more specific diagnosis. These are the ones we're going to go through. So hopefully this rings a bell as you see this outline. Soap bubble, tennis racket, honeycomb. So we'll go through each of these individually and what you should think of first, and maybe one or two other things that should come to mind when you see that appearance. All right, so hopefully you can recognize these as well. What do we call this? This is multilocular, and especially that one, it really looks like... There's your sound cue. Now with some fresh sounds in this presentation. So these are all what I would term soap bubble, right? Different size round loculations. And so what do you think for soap bubble? Hopefully the first thing that comes to mind is Ameloblastoma. What else could it be? Maybe one of those other MACHO lesions. Could be an OKC, could be myxoma. Myxoma more the angulated septae though. And sorry to give away the next one, but what do we see here? Those angulated septae, very polygonal. This one happens to be quite square, but you see a lot of them. They just look angulated. And so that's what I describe as straight septae, or some of the books call it tennis racket appearance. Oh, there's your Waluigi racket. And so that's your tennis racket appearance. And what should you think when you see this? In most cases, it's going to be a myxoma, but you should also think maybe hemangioma. All right, this was the same one we used for soap bubble, but it is very small loculation. So and it kind of looks multilocular, but really small loculations. What type of things should you think? Or what's the description first? Sorry, no sound effect for this one. Honeycomb. So honeycomb appearance, and that should make you think what? Hemangioma is a big one we talked about, but also Ameloblastoma when it just has those small loculations. There was one that looked kind of like this one that was from our internal calcifications lesions, and that was the CEOT. And then maybe consider myxoma as well. All right, this one I just kind of touched briefly on, but when you have these small but very round loculations, maybe the location of this one, so think location specific, is giving it away. But this is our grape cluster appearance. And we said this was a very specific type of lateral periodontal cyst, the botryoid variant. What else might you think? Maybe a small hemangioma, an ameloblastoma always starts small. But that specific description was used for lateral periodontal cyst, the botryoid variant. All right, what are we describing here? It's more the internal appearance rather than the round sphere, but what's that internal appearance of both of these? In this case, it's all over the bone, the entire mandible. You can notice the changes in the maxilla as well, so that's a systemic condition. But that internal appearance, that's going to be your ground glass, and you should think something fibro-osseous. And so this is a Ameloblastoma that internally can have a fibro-osseous type appearance. This is our classic fibro-osseous lesion, our fibrous dysplasia. And then what did we say when it's systemic? Maybe you remember this specific radiograph from the systemic lecture, and that's our hyperparathyroidism. What else might occur? Ossifying fibroma can have a ground glass appearance. Semino-osseous dysplasia, the internal when it starts to calcify, that has a ground glass appearance. And then what's specific about this one? We again have our multilocular appearance in this one, but not so much this one. And so I'm talking about what it's doing between the roots of the teeth. And this is scalloping. And I said there's two main things that should come to mind for scalloping, and that's going to be your simple bone cyst. Oh, let's get our image up here. There's our scallop. That's going to be our simple bone cyst and an OKC. Those are the ones that really tend to scallop. Others may do it, but not quite as distinctly as those two. And specifically, we'll get to this one next. So more specifically, when that lamina dura is intact, that is your simple bone cyst. Maybe a focal osteoporotic bone marrow defect. You know, these things that aren't true cysts or tumors that don't really tend to resorb bone. And so they leave that lamina dura intact. It's like having a magic barrier around these teeth. So just the same as we all know the story of when Dumbledore tried to attack Gandalf. Imagine this barrier intact preventing that thing from resorbing the lamina dura. That's a pretty specific appearance. All right, what do we call this? It looks like little tufts of wool. You should think that. Cotton wool appearance. The biggest thing we think is Paget's disease. That's the most classic one for your cotton wool appearance. And that's what this one is here, especially when you see some hypersematosis with it. That's classic for Paget's disease. But some of the other fibro-osseous things can do it. And so fibrous dysplasia, ossifying fibroma. So think of this as maybe a variant of fibro-osseous appearance. Sometimes semino-osseous dysplasia can appear cotton wool. All right, this should be an easy one, hopefully. You see that? So you see that radiating appearance of the periosteal reaction. Shine bright like a diamond. That's your sunburst or sunray appearance. What's the first thing that comes to your mind? Osteosarcoma when you see that. There are a few other things that can do it. And in fact, this is an example of a hemangioma, which can cause the sunburst appearance. Also, Ewing sarcoma, metastases, and then there were two very specific metastases. Those were the ones that produce calcification, and so our breast or prostate metastases. And in some cases, a myxoma can do it. So most of the time when you see this, it's kind of foreboding. Either a malignancy or a hemangioma could be potentially dangerous. But this is our classic sunray appearance of osteosarcoma. So that should for sure be the first thing that comes to mind, osteosarcoma. Remember that one. Well, what do we call this? So in this case, I'm kind of describing the radiating outward appearance. That's our spoke wheel appearance. There's a couple main things that can do this. Sometimes Ameloblastoma can create that spoke wheel appearance. And in some cases, hemangioma. So hemangioma is one that's kind of coming up over and over. And then if it's a periosteo reaction that's doing it, what's it going to be? It's going to be our, like the last slide, sunray appearance, so osteosarcoma. So this is a hemangioma. That you should be able to identify right away. That's a Ameloblastoma. All right, so you see this one, and hopefully by now, with enough of my lectures, you immediately think of Shrek or onion skin. Because why? There's our onion skin appearance.
Ogres are like onions. Onions have layers. Ogres have layers.
Okay, so ogres are like onions. That's why I always think of Shrek, because of the onion skin appearance. But what does it mean diagnostically? You should think osteomyelitis, right? The first thing you think, the most common thing that create the onion skin appearance, the parallel periosteo reaction, that's osteomyelitis. But then there are a couple of malignancies that can do this. So your Ewing sarcoma, your Langerhans, leukemia. But much, much more common when you see that, it's going to be an infection. All right, how about this one? Do you appreciate these well-defined? Maybe you describe it as lightly corticated, but the books always describe these as non-corticated, multifocal lesions, not multilocular because they're separate lesions. We call that.
I know the art of fight. I know the art of war. That's all I ever studied. That's why I'm so feared. That's why they feared me.
Wow, that's Mike Tyson there. Forgot I had that quote in there. But this punched out lesion, and this is the classic appearance of, first thing that come to mind should be multiple myeloma, and in some cases Langerhans or metastases. So something not good, right? Something that's more of a malignancy that really tends to extend into bone. And in this case, what are we seeing? We're seeing that periosteo reaction, but we just said Langerhans can do that in some cases. And if we think back to our multifocal lecture, how is this different from something like basal cell nevoid? Well, if you think multiple OKCs, they tend to be larger, definitely more well-corticated, kind of more established lesions. For these, you can imagine more like metastatic, more like things just metastasizing through the blood and entering into the bone. All right, what was this one? What are these lesions doing to the bone here? They're undercutting it. That undercut appearance is...
Ice cream.
There's Forrest Gump for you, reminding you of the scooped out appearance, which the first thing that comes to mind is hopefully Langerhans. So how is this different from a periodontal lesion? Periodontal lesion usually arises from the top, and sometimes you have an angulated defect against the root of a tooth. Rare is it going to kind of scoop under a bone. Sometimes periodontal/endodontic lesions can do that, but then you'd expect it more at the apex. And so that's a classic appearance for Langerhans cell histiocytosis. And I've shown you this one enough that hopefully you see what I'm getting at. See the radiolucency around here? Maybe the internal structure is more the ground glass, but with that radiolucency, you're seeing what? Irregular PDL space widening. Remember, malignancies like to follow paths of least resistance, and they just kind of penetrate into the PDL space like this, create kind of a ill-defined radiolucent halo around the roots of teeth, and so that's a bad sign. Both of these also appear radiopaque, so you'd think osteosarcoma first, or do they have a history of breast or prostate metastasis, and that can look just like it. On close inspection, you see a little bit of a sunray appearance in this case, so maybe that tells you what it is. All right, this is the same image from that one, but now we're focusing on the effect on the roots, particularly that premolar. That's not a normal shape to a root. Usually they're a little more rounded at the apex, and especially this one. So very spike-shaped, so spiked root appearance. What does that mean? Typically, it's a sign of malignancy. So this is our osteosarcoma again. This is some unknown malignancy. And classically, it's tough to distinguish between malignancies on radiographs unless you see that osteosarcoma appearance, and then it's one of the calcifying type of malignancies. So typically osteosarc, chondrosarc, breast or prostate metastases. But when it's just radiolucent like this and you have that spike root appearance, could be a squamous cell carcinoma that typically arises from epithelium. So think of a gingiva tissue extending into the bone. This one happened to be a clear cell odontogenic carcinoma. So a really rare one that we haven't even talked about. Here I see more spiked roots, but I see teeth that just look like the bone is destroyed around it. What do we call that? Well, that is our floating teeth, which tends to be a bad sign. Of course, you could have periodontal disease, very severe periodontal disease, periodontal endodontic lesion that does this, so it could be inflammatory. But floating teeth is a classic appearance of malignancy. Here's another one. See how it's just destroyed the alveolar bone here? It's very ill-defined. Screaming goat for you. To remind you that floating teeth a lot of time is a classic appearance of malignancy. This is a squamous cell carcinoma. All right, how about in this case? A little bit different. Maybe we could focus on the floating teeth, but let's look at the borders in this case. You can also notice a pathological fracture. Are these well-defined or ill-defined borders in both of them? You might argue, well, that's well-defined, but look at all the trabeculation left behind. That's a really ragged border, or in this case, you might describe it as moth-eaten appearance. If you're not sure what we mean by moth-eaten, I think this is a good example, where it's just leaving trabeculation behind in a really irregular fashion. And so most of the time you see that, think malignancy. It could be an aggressive inflammatory, but I've never seen inflammatory to quite moth-eaten like this. And so all of these are signs of malignancy. Both of these are squamous cell carcinomas. All right, so that does it. We covered these 15 descriptors, and these are the cases where radiology means a lot. You know, in some cases, radiology, it's really tough to distinguish one from another thing, but when you see these specific appearances, although we can't necessarily distinguish what type of malignancy in a lot of cases, you'll see a lot of these, they really narrow down your differential. And so hopefully you see any of these and you can pull out your Shakespeare and start getting really descriptive and say, ah, yes, that's the classic sunburst appearance, which means it's likely osteosarcoma or whatever the case may be. And that'll help out your surgeon, your oral pathologist quite a bit, because getting to the proper diagnosis is the first step in a proper treatment. And so hopefully this can help you out throughout the course of your careers. But that pretty much does it for my lectures. So thanks for bearing with me, and I'll see you in clinic. Ask me any questions you have about radiographs, about how to take radiographs. If you do come to my office, just remember, bring a burrito. Thanks. Bye.